A newborn infant presents with bilious vomiting and epigastric distension within the first 24 hours of birth. I am showing you the initial abdominal radiograph. Describe the findings.
Okay, looking at the images, this abdominal radiograph demonstrates a classic double bubble sign. The large, gas-filled bubble in the left upper quadrant represents the dilated stomach. The second, smaller bubble to the right, represents the dilated proximal duodenum. Crucially, there is a complete absence of distal bowel gas throughout the rest of the abdomen. In addition to these bowel findings, dextrocardia is present with situs solitus, and a right femoral line is noted. The primary diagnosis is complete duodenal atresia.
What are the other common causes of a double bubble sign in a neonate?
Okay, the differential diagnosis for a double bubble sign includes annular pancreas, a duodenal web, and midgut volvulus secondary to malrotation. Annular pancreas occurs when a band of pancreatic tissue encircles and obstructs the second part of the duodenum. A duodenal web typically causes an incomplete obstruction, meaning we would expect to see small amounts of distal bowel gas. Finally, peritoneal bands known as Ladd's bands can cause duodenal obstruction in the setting of malrotation.
What is the underlying embryological pathophysiology of duodenal atresia?
Pathophysiologically, duodenal atresia is due to a failure of recanalization of the duodenal lumen. During early embryonic development, between weeks 8 and 10, the lumen is temporarily occluded by proliferating epithelium. A failure of this solid core to recanalize results in complete atresia, which is twice as common as stenosis. The obstruction is almost always located just distal to the ampulla of Vater, which perfectly explains why the infant's vomiting is bilious.
Duodenal atresia is associated with several congenital syndromes. Can you discuss these key associations?
Duodenal atresia is strongly associated with Down syndrome, which is present in nearly a third of all affected patients. It is also a key gastrointestinal component of the VACTERL association. VACTERL stands for vertebral anomalies, anorectal imperforation, cardiovascular anomalies, tracheoesophageal fistula, renal anomalies, and limb anomalies. The presence of dextrocardia in this patient strongly suggests an associated cardiovascular anomaly as part of the VACTERL spectrum.
How would you manage this patient as a radiologist?
In that case, as a radiologist, I would carefully review the chest and spine films for any vertebral anomalies that could indicate VACTERL association. I would also suggest obtaining a formal echocardiogram and a renal ultrasound to screen for further hidden anomalies. Clinically, the patient requires immediate gastric decompression via a nasogastric tube and aggressive correction of fluid and electrolyte imbalances. Finally, I would ensure urgent referral to a pediatric surgical team for definitive operative repair, typically a duodenoduodenostomy.